Hello, this is Marlene Buchanan, and we are going to do an overview of the endocrine system. We did cover this in class, but I feel like probably we could use a rerun. So we'll advance to the next slide here, if I can get it to go. Okay. Okay, we know that functions of the endocrine system are related to reproduction, growth and development, regulation of energy, fluid, and electrolyte management. We know that we're talking about the growth hormone here. We're talking about the thyroid with regulation of energy. We're talking about, of course, the hypothalamus and the pituitary gland. With reproduction, we're talking about follicle-stimulating hormone, luteinizing hormone, testosterone, estrogen, and prolactin and oxytocin. And then with fluid electrolyte, we're talking about those that are affected by the endocrine system. And you will not be held to know information about the reproduction. That will be in another slideshow. Okay, and there's the major hormone secreting glands of the endocrine system. And you have the hypothalamus, the pineal gland, the pituitary gland, which is known as the hypophysis. We have the adrenal hypophysis, which is the anterior pituitary, which makes up 80% of the gland. And then you have the neurohypophysis, which is a continuation of the neural network from the hypothalamus, and has very important work to do that we'll talk about in a minute. We have the thyroid, which, remember, that's your energy gland. We also have the thymus gland. We have the adrenals that sit on each side of the kidney. Oh, I failed to mention, with the thyroid, you have the parathyroid gland, which regulates calcium and affects phosphorus also. And then we also have the islets of Langerhans in the pancreas, which we'll talk about the pancreas and its functionaries, the ovaries, and the testes. Okay, and here's another picture of the different glands, and shows location of the adrenal glands on each side of the kidney. Much better drawing than I could do. Thymus has to do with antibody antigen. We will not be talking about disorders of the thymus. There's your hypothalamus, and then tucked underneath of it is the pituitary gland. Okay, and this is just a rerun of what we just talked about. Whoops, our thing is jumping back the wrong way for some reason. Okay, let me find it. Okay. There it talks about the two types of glands we have in our body. We have endocrine glands, and they secrete their substances directly into the blood to exert their effects on target organs. We have exocrine glands that secrete directly into a duct, and that would be your salivary glands and your sweat glands. Okay, I'm having problems with my slideshow here. It doesn't want to advance like it should. Okay, we'll get this fixed here in a second. Patience is a virtue. Okay. There it talks about water hormones. They are substances secreted directly in the blood. An example I have is thyroxine T4, which is produced by the thyroid gland. Again, we talked about the effect of energy in the body, the metabolism of food that we eat, the byproduct of energy that we need. It affects our level of energy. It affects our ability to have a normal bowel movement. It affects our mood, so we'll talk more about that when we talk about hyper and hypothyroidism. Target tissues are organs affected by the hormones, and all body cells are affected in that organ. Okay, hormones are secreted in small predictable amounts, and they circulate through the bloodstream, and they bind to receptors in the cell. An example I gave you in class was when epinephrine is released from the adrenal glands, that it'll go to the heart cells, and there are special receptors on the surface of the cell of the heart that are specifically made like a lock and key to connect with the epinephrine. And then when they are connected, then that causes a response of increased heart rate and vasoconstriction. And so it makes sense if, you know, the beta cells in the heart connect with epinephrine to stimulate this response by the sympathetic nervous system. If you gave someone a beta blocker, you would blunt that response. Now, you cannot block all the receptors on the cell, but you could block several of them. So that's an example of that. Here are the hormones' influence. We talked about the influence of estrogen and FSH on reproduction. Cortisol is a biggie, responds to stress, pain, excitement released from the adrenal cortex. And then fluid electrolyte balance, we will talk about the influence of ADH, antidiuretic hormone. It is released by the posterior pituitary. Of course, it is manufactured by hypothalamus, goes to the posterior pituitary. It stays there until a trigger causes its release. The appropriate trigger would be a change in serum osmolarity. If the serum osmolarity goes up, you're in a dehydrated state. Thus, ADH will be directed to be released. It will go to the distal tubules. It will cause the distal tubules to reabsorb blood that has been filtered, and instead of an endpoint being more urine, there will be less urine. The blood that's been cleansed and filtered will be returned to the circuit to help maintain fluid balance, restore it, and then the serum osmolarity will come back down to where it belongs. We know that the renin-angiotensin-aldosterone system, when it is triggered by a low sodium or a low circulating blood volume to the kidney, low blood pressure, that the renin system is stimulated by the kidney, goes to the liver and converts into angiotensin 1, then angiotensin 2, which are very potent vasoconstrictors that then go to the adrenal gland, the adrenal cortex, and says let go of aldosterone. Aldosterone then goes to the tubules and tells the kidney, when you are doing your filtration, reabsorption, and excretion function, I want you to reabsorb sodium. When you do that, the net result is water follows to help restore the circulating balance, restore blood pressure. Calcitonin, it's produced by the thyroid, and we know that it is influenced by calcium levels, and it will cause calcium to be pushed into the bones, which is a good result. It's what we want. If we have not enough circulating calcium, we have parathyroid hormone released by the parathyroid gland, and it pulls, P-U-L-L-S, pulls calcium out of the bone into the blood when there is a lowered calcium level. And the trigger is circulating lower calcium level causes PTH to be released from the parathyroid. Its influence is on the bone to let go of calcium. When that happens and the calcium level is restored, it's a feedback, which means now that you have restored the level of calcium, the production of PTH will stop. We talked about the thyroid gland in relation to energy, and it produces T3 and T4. And then the growth and development hormone is critical also. Now let me see if I can get this advanced easier than what's been doing. Nope. There we go. Hormones attach to receptors within the cell and the cell membrane. They only act on cells that are specific for that hormone. Some are lipid soluble, and those are your steroids, your thyroid hormones. All others are water, but you don't have to know that to apply the information. There's regulation and feedback, and then what you want to get out of this is that there is a mechanism called feedback that will regulate the continued release or stop the release of the hormone. And then it gives you the examples. Nervous system control, pain, emotion, sexual excitement, stress. These cause the sympathetic nervous system to be stimulated and release catecholamines, called your fight or flight. You have 3 that are released from the adrenal cortex, and that would be your, from the adrenal gland, and that would be your epinephrine, your norepinephrine, and your dopamine. We are also aware that they can become neurotransmitters if they stimulated release through the neural system and they cross the synaptic junctions from neuron to neuron to create a response of an elevated heart rate. So there's 2 ways it can be used, either directly on the central nervous system, or it can be dumped into the blood from the adrenal gland. We have circadian rhythms. We know that cortisol has the peak in the morning and then falls during the day, and it's at its lowest rate at night. And we know the growth hormone is highest at night when a person is sleeping, which is what we want. And there it shows circadian. Okay, releasing hormones from the hypothalamus. They stimulate release of hormones from the anterior pituitary. An example is TRH, thyroid toxin hormone, receptor hormone, goes to the goes from the hypothalamus to the pituitary and tells it to release TSH. And this TSH goes to the thyroid and tells it to release T3 and T4. So TSH, thyroid stimulating hormone. That's the one that you really want to focus on. Don't worry about the TRH. The TSH you do want to know because we can do serum blood levels of TSH. We have inhibiting hormones that inhibit release of hormones from the anterior pituitary, and the example given is somatostatin. It inhibits the growth hormone so that we have a balance between growth that is at a regulated rate and not out of control. So somatostatin is a balance to the growth hormone. And neurons receive input from the brainstem and from our limbic system. And then there shows the different glands, and we're not going to get all muddied on that picture. From the anterior pituitary, the release of TSH in response to lowered T3 and T4 levels. We have adrenal corticotropic hormone that is sent to the adrenal glands to release cortisol. And then we have FSH and LH, which we're not going to focus on. And then we have non-trophic hormones, and that will be your growth hormone and your prolactin. Posterior, which is neurohypothesis, there's the antidiuretic hormone. It regulates fluid volume by reabsorption of water in the kidney tubules. It does respond to an elevated serum osmolarity, decreased blood volume, and blood pressure changes. It is inhibited by increased fluid volume, which makes sense. Alcohol also influences and will block the release of ADH, and that's not good. Someone's drinking and thinks they're taking care of fluid needs. They are not. And then certain drugs called beta agonists can block the release of ADH when we need it. Oxytocin is a release from the posterior pituitary when there is stimulation of mom's nipple, and it stimulates milk letdown. It's important also for uterine muscle contraction, which you'll learn more about in OB. It helps for the uterus to contract and then shrink after delivery. Thyroid, it's located in the anterior neck. It does look like a little bow tie shape. We need iodine to synthesize hormones. A long time ago, before the discovery of iodized salt, there were many people that suffered from a thyroid deficit. Thyroxine is our most abundant T4, but T3 is the most potent, and then we already talked about calcitonin being released to lower a serum calcium level by pushing it into the bones, or into the bone marrow. Parathyroid, we know that we could have up to 9 of these glands, but we know for sure that we have a minimum of 4. They're paired on each side of the thyroid, and the mechanism here is a hormone that's triggered to be released based on circulating serum calcium level that has fallen below the expected value, and thus PTH, parathyroid hormone, will be released, and it will cause calcium to be removed from the bone and back into the bloodstream. And once that is restored, then the release of PTH will halt. We have a pair of adrenal glands, one in each kidney. They do act independently of one another. So if you did have surgery and had adrenalectomy of the right adrenal gland, you can still have proper functioning of the adrenals. The medulla is the 10 to 20% of the gland. You know, the cortex was the outer, and we talked about cortisol, and your mineralocorticoids come from there. From the medulla, the interior portion is where those three catecholamines come from: epinephrine, norepinephrine, and dopamine. The cortex, here we said think about sugar, salt, sex, because glucocorticoids is just what it says. It is a steroid that influences glucose. So the release of cortisol, which really, if you think about it, if you needed to run and you were scared, you would need more glucose released to the body, to the cells. So that would be a good outcome. Unfortunately, sometimes people release too much cortisol, and it does cause a weight gain, moodiness, and elevated blood sugar. Then salt, when you think about salt, we're talking about mineralocorticoids. Aldosterone influences minerals. The mineral that it influences is sodium and potassium. So it is, since it influences electrolytes, which are minerals, then you could remember that mineralocorticoid is aldosterone, part of the renin-angiotensin-aldosterone mechanism. Aldosterone is released in reflection to a lower blood flow to the kidney, low blood volume, low blood pressure. Low sodium can trigger the release of aldosterone, and it stimulates the distal tubules to reabsorb sodium, and water follows it, and potassium is excreted. And then we have the androgens, which we're not going to get into. Adrenal cortical hormones. Cortisol is the most abundant and potent glucocorticoid. Sorry, I'm not saying that correctly. It regulates blood sugar. It responds as an anti-inflammatory response during stress. It is affected by circadian rhythms. We know that we can measure cortisol in the morning when it is its highest, and it drops during the day, and it's its lowest at night. Then it starts picking back up right before you wake up in the morning. Aldosterone is a potent mineralocorticoid, and that is misspelled there. It maintains vascular volume by reabsorbing sodium, and then water follows it. The pancreas is located behind the stomach at lumbar 2. It has endocrine and exocrine functions. The hormones that we're talking about is glucagon, which is released in a response to a lowered blood sugar. It causes glucose to be released from the liver and elevates your glucose level back up. Insulin is the opposite mechanism. Insulin is released in response to elevated blood sugars and will bring them back down by shoving glucose into the cell. Somatostatin we already talked about, and pancreatic polypeptide I'm not going to worry about. There it is, glucagon is secreted from alpha cells. It assists with control of blood glucose. It converts glycogen to glucose, helps to utilize fats and amino acids. Insulin regulates metabolism and storage of carbohydrates, proteins, and fats, so you can see how important diet is to a diabetic. It facilitates glucose transport across cell membranes, so that's facilitated diffusion, and we know that a problem with diabetes type 2 is where the cell becomes resistant to the work of the insulin and will not allow it to shove the glucose inside the cell as readily as it had in the past. So it's like somebody changed the key and the lock on the door, so it needs a new key. Effects of aging, you do have decreased hormone production secretion, so you know that under stress a person would not release as much cortisol. They would not release as much of the catecholamines. It could even influence their thinking, altered hormone metabolism and biological activity, decreased responsiveness of target tissues. So that says that the hormone, if it's released, that the target tissues don't respond very well to it. It's like they're half asleep and they don't have much of a response, and it's not adequate enough to support the body. Also, they have altered circadian rhythms and may wake up frequently, so that interferes with rest and repair. There is your functional health patterns. You can read that for yourself on how you would assess somebody to figure out if they have some type of endocrine disorder. There's the elimination pattern. We see there that it bolds that constipation can be seen with diabetes because of nerve impairment of the gut, and hypothyroid person would tend to be constipated because of the decreased metabolism and decreased peristaltic activity. If we're hyperthyroid, we'll tend to have liquid loose stools. There's activity exercise pattern. Energy level may be increased or decreased depending on the disorder. Fatigue or hyperactivity, inability to maintain previous level activity, a change in heart rate or blood pressure. There is sleep rest. There's cognitive perceptual pattern. And, you know, we talked about with steroids, you could see mood change, apathy, depression. All of these things could be involved with different parts of the endocrine system, which we'll cover in more detail. There's self-concept, self-perception. We talked about with steroids, if you get too many, you could have a moon face, increased adipose tissue deposited on the trunk, thin skin, which would be back under nutritional metabolic, fatigue with different endocrine disorders. There's role relationship pattern. Here's sexuality reproductive pattern, which we will not really get into that. When we do male reproductive, we'll cover male sexual dysfunction. There's coping stress, value, belief. Here's physical assessment, what you would assess for checking for any problem within the endocrine system. There are diagnostics tests that we can do. We can check the growth hormone level. We can check the cortisol level, but it would have to be drawn in the morning. The person would not be allowed to drink any caffeine or take anything that could alter the results of the test. We can do urine test, X-ray, CT, MRI. Here's pituitary function with the growth hormone, prolactin, and TSH and ACTH. We already talked about that. You can look at your notes from class or what I referred to earlier. Again, FSH and luteinizing hormone we are not going to focus on. But if you can make a definition of thyroid stimulating hormone, why would it be released? A definition of adrenal corticotropic hormone, and where is it released from and what is it influence? I hope you're thinking released by the pituitary and influences the adrenal gland to release cortisol. There's the thyroid. We can do a TSH level. We can do a T4 or T3. We can do a T4 and TSH. We can do a radioactive iodine uptake, and remember what we said about that in class. Parathyroid, we can check the PTH level. We can check the calcium level. Sometimes when a person has a persistent elevated calcium, it's usually due to a tumor of the parathyroid that could disrupt the release of influence the release of PTH, and there's too much released and the calcium level stays elevated. And there's not enough calcitonin from the thyroid to act against it. And we know that phosphorus influences the calcium level. If we have a high phosphorus, we'll have a lowered calcium level. And so that is an issue also. Adrenal studies, cortisol, you want an early AM sample, and you also want to minimize stress. Make a note here again about no caffeine. We can check aldosterone and ACTH. That's all vascular test. Then urine test, we can also check for aldosterone, cortisol. Vanilla mandelic acid has to do with a pheochromocytoma, which is a tumor of the adrenal gland, which we will talk about later, but I'm not going to hold you to knowing about that test. And then, of course, abdominal CT scan, we could view organs within the abdominal cavity to see if there's any problems there. Pancreatic studies, certainly fasting blood sugar. We really want that to be 70 to 110. Some books are even getting, some physicians are getting tighter on that and would like to see it 70 to 100. Glucose tolerance test, remember there's a 2-hour glucose tolerance test. It's typically done to diagnose a problem with diabetes. There's a 4 to 6 hour glucose tolerance test, and that one is done to diagnose hypoglycemia. And the point is, if we have you drink a sickly sweet substance, and then within a certain amount of time draw blood, we'll see the blood sugar going up. The next one, we should see it coming down some, because if you have enough insulin released in the pancreas, it should bring it back down. When you do the 4 to 6 hour one, the problem with it is if you have a problem called hyperinsulinemia, meaning the pancreas is hypersensitive to circulating blood sugar levels and will trigger the release of too much insulin and bring the blood sugar down quickly, that's called that is called a problem with hypoglycemia. So be aware of that. Then there is a capillary blood glucose, which we call that glucose monitoring, that we can do at the bedside with a finger stick. Glycolated hemoglobin, that's hemoglobin A1C. Red blood cells usually last about 3 months circulating before they're completely dead, and they land in the graveyard of the spleen. And also they're broke down by the liver too. So if we know it lasts 3 months and we have this strand of sugar wrapped around the hemoglobin, we can measure with consistency what the average blood sugar level was for the last 3 months, and that's your hemoglobin A1C, and anything 7 or over is not good, and so a person could cheat and we'd catch them. Before we had the development of the hemoglobin A1C, where we could do a retrospective back look for 3 months on the trend of the average of the A1C, people could fast and be good for the day before they go to see their doctor, and they'd say, well, your blood sugar's good, when really they've been cheating. We can check the urine for glucose and ketones, because a urinalysis should not have that in there spilling over unless there's a problem with excess production. And of course, again, abdominal CT scan. Your nursing role is, of course, to explain it to the patient, assess them for any allergies. A biggie is if you know they're going for a CT with contrast, you need to make sure they do not have an allergy to shellfish or iodine, because iodine, although it's used in lower amounts for contrast, it's still present, and they could have an anaphylactic reaction if they're allergic to it. So do screen them for any allergies, especially allergy to contrast dye. You want to get informed consent, meaning a physician or a healthcare provider, nurse practitioner, or PA has thoroughly explained the benefits and the risk of this procedure and why they need it, and you are just saying they're in their right mind when you sign it, and that they've told you that they've been informed of all these things. And of course, any aftercare patient teaching. Okay, that's the end of this, and I will do another collaborate talking about pituitary problems. Thank you very much. Hello, this is Mrs. Buchanan, and I am doing a review of anterior pituitary dysfunction, and we already covered this in class somewhat, but we're just going to go over it again. Here we're talking about the growth hormone, the thyroid stimulating hormone, TSH, the adrenal corticotrophic hormone, ACTH, and we are not going to get into the FSH or the LH. We'll talk about, and prolactin we won't really focus on much either, but you need to know that that is anterior hormones. Growth hormone, it is an anabolic hormone, meaning build up. It promotes protein synthesis, mobilizes fatty acid. If you do not have enough growth hormone as a child, then the condition would be called dwarfism. If you, as an adult, have too much, and the other opposite of that would be if you have too much growth hormone when you're a child, you need to make the note of, it's called gigantism, because their bones will lengthen and they can be very tall, like Andre the Giant. If you have oversecretion of the growth hormone as an adult after the epiphyseals at the end of the bones have sealed off and you no longer can have longer bones, then the muscular tissues will get bigger and the bones will get thicker and wider. Thus, the head will enlarge, the nose, the lips, the hands, and the feet will enlarge. Growth hormone excess is typically caused by a tumor of the pituitary gland. You have unwanted growth of bones and soft tissue. You have elevation of blood glucose. And there's insulin antagonism, meaning that even if they're releasing insulin, the blood sugar level in the cell is resistant to the action of the insulin, so the blood sugar stays elevated. Again, in childhood, excess growth hormone causes gigantism. In adulthood, typically middle-aged adults, more women than men, the condition is called acromegaly. Acromegaly develops after closure of the epiphyseal plate. It occurs across the gender, but again, it can happen more to women than men. There is increased mortality rate with this disorder because there is a lot more circulating blood going around and has to travel further, so the person's heart will begin to fatigue. The only way the heart knows to increase stroke volume is to increase heart rate and contractility. But over time, as it starts to pump more forcefully, it'll cause increased growth of cardiac tissue, and that is called cardiomegaly. Then you have inefficient contractility occurring, and it's not a good squeeze with each heartbeat. Eventually, the left ventricle, which is the workhorse of the heart, will start to hypertrophy, and you have left ventricular hypertrophy. As a result of this increased circulating volume through this longer circuit, because the person is bigger, you will have elevated blood pressure to get it through, and they develop hypertension. Also, they have excess glucose and insulin antagonism, so they can develop diabetes. It's a gradual development, 7 to 9 years onset to diagnosis. Here we're talking about acromegaly. There's enlargement of the hands and the feet. All of a sudden, the hats and shoes and gloves don't fit like they used to. They have severe joint pain, develop arthritis. Their facial features enlarge and thicken. Their tongue can enlarge and thicken, and the symptom that you would expect to be displayed from an enlarged tongue would be difficulty in speech. It's called dysphagia. They also can have sleep apnea because of the thicker area in the larynx, and so they have some airway obstruction, and they will have sleep apnea due to this airway obstruction. They will have dry skin, polyuria, polydipsia from the elevated blood sugar, hypertension. The heart can begin to suffer and have pain called angina, where there's decreased blood flow to an area. They can develop congestive heart failure because the left ventricle has failed, and fluid will back up to the left atrium and then back into the lungs. Visual disturbances and headache from the excess volume, hyperglycemia and glucose intolerance, and arteriosclerosis. Diagnostics test to test for acromegaly. They can check the plasma growth hormone level. They can check the IGF-1, insulin-like growth factor, do a glucose tolerance test, do a CT to localize a tumor, because we mentioned a tumor is the most common cause, do an MRI to get more precise slices of the brain, and do an ophthalmic exam. Treatment is remove the tumor. So they'll have a hypophysectomy, and depending on where the tumor is, that would be the whole pituitary glands removed. If they just need to remove part, they would tell you that also. We would give sandostatin to suppress the growth hormone, and it's another type of somatostatin that we talked about that keep each other in balance. Also, they might need radiation and surgery. Radiation before surgery, reduce the tumor size to make it easier to remove. And the surgery that you'll need to be aware of is transsphenoidal hypophysectomy. The incision is made between the upper lip and the gingival tissue. The tumor is removed via the sphenoid sinus. Results can be expected within weeks of the growth level hormone falling, depending on the size of the tumor. This is a very sensitive area. It's very close to the brain, to the meninges, and so you want to be aware of that if you are taking care of this client post-operatively, which we'll talk about here in a minute. There you can see the approach where they're going in through that area that we talked about. And it's made in the inner aspect of the upper lip and the gingival tissue. The sella tertia is entered through the floor of the nose and the sphenoid sinuses. So you can see if you have a violation of this area and you have what's called a leak, cerebrospinal fluid could leak out and drip through the nose as a clear drainage. Let me make sure I didn't skip anything here. Okay, no, I did not. Okay. Radiation therapy will be done to reduce the tumor size prior to therapy. It is a secondary option if it's an inoperable tumor, and all they can do is radiation therapy. Just be aware of they will mark the skin so they'll know exactly where to focus the radiation, but it can cause irritation and burn-like on the skin. That if a person can develop hair loss, changes to the oral mucosa. They may need a stereotactic frame attached to their head with pins and do radiosurgery for that, and then your responsibility would be taking care of the insertion site so they don't get infection there. Drug therapy, somatostatin analog. The most common, the generic, is octreotide. It can be given IM, IV, or sub-Q route to inhibit growth hormone. They may also give them pegvisomant, which is a growth hormone antagonist, and it can be given sub-Q. And they also could give a dopamine-like substance that antagonizes it. It's called cryptine or parlodel, and it can be given PO. Pre-op care, of course, you want to get an informed consent. You want to alleviate any anxiety. They need to be as calm as possible. They may need prophylactic antibiotic nose drops to prevent infection. And of course, you want to promote good oral hygiene. You also want to teach them what to anticipate to happen post-op and the care they'll require, and how you don't want them to cough forcefully or to sneeze. You want to head the bed up 30 degrees. Now, we're going to cover this in a minute, but it doesn't hurt to repeat. And you always want to teach a pre-op patient what to anticipate post-op, the care they'll receive, pain management, medication, knowing that they may forget it early on in the post-op period, and you'll need to reinforce the teaching and bring it up again. Post-op care, head of the bed must be elevated to 30 degrees. They must not brush their teeth. Sometimes you can use a gentle, soft sponge to gently clean, but not anything vigorous that could cause interruption of the incision line or disruption of the incision line. They are not to have a forceful cough, sneeze, or Valsalva maneuver. You do assess for nasal drainage. If you see any clear nasal drainage, you are to collect it and send it to the lab. Or if they're in the ICU, they can do a spot check for glucose. And if the glucose level is at a certain amount or greater, and you don't have to know the number, then it is indicative of a CSF leak, and they could develop a headache due to this leak. It is usually self-limiting, and the leak will resolve within 72 hours. You are to assess their LOC every hour to every 2 hours, and that is where I'm talking about neurostatus. And that is the Glasgow Coma Scale, eye-opening of pupils, ability to follow commands and move all extremities without difficulty, and they're oriented. They'll need analgesia for headache, pin care. If they do have the stereotactic frame, they may or may not have that. Of course, it's important to monitor for intake and output. Because they did remove this tumor, they could cause an inappropriate blockage of ADH, and if ADH is completely blocked, they will develop a condition called diabetes insipidus, and that's called the syndrome of PPP. And when that happens, then their serum osmolarity is going to go up really high, and they're going to be peeing like crazy. They're going to be very thirsty, and nothing's going to help it unless we give them lots of fluids, which we'll talk about when we talk about DI here, a little more detail in a minute, because there's different types of diabetes insipidus or DI. Of course, skin care is important for status post-radiation if they receive that treatment. home care. They will need to be on hormone replacement therapy for life if they remove that part of the pituitary gland. They'll have to have ADH and cortisol and a thyroid hormone. They'll need the thyroid hormone because TSH will be gone and won't be released in response to T3 and T4 levels. And they won't have the adrenal corticotrophic hormone going to the adrenal gland and saying release cortisol when necessary. And again, we talked about if there's no ADH to help regulate fluid serum osmolarity and fluid volume, then we're going to have to give them ADH therapy. An excess of trophic hormones, if you have too much adrenal corticotrophic hormone, that situation is called Cushing syndrome, and there's excess cortisol being produced, and the person will get the moon face, adipose tissue deposit on their trunk. They'll tend to have thin, frail legs. They can be prone to fractures. Their TSH will crank out too much, will cause a hyperthyroidism state. If they have hypofunction of the pituitary, well, that's very rare disorder, usually a result of in-organ failure. So you don't see that very much. Okay, now we're going into information that I don't think we started yet in class. And that's disorders of antidiuretic hormone. So we're going to talk about SIADH, syndrome of inappropriate release of ADH. So if you know if ADH has been inappropriately released, it means that it is not responding to a trigger of the serum osmolarity. It's ignoring it. It's being released regardless of what the serum osmolarity is and the fluid volume. So ADH is released inappropriately when we don't need it. ADH tells the distal tubules of the kidney to hold on to fluid. So this is the syndrome of no P, P-E-E. Then we have diabetes insipidus, which we just mentioned, and that is where ADH is not produced, it's blocked, and when it's blocked and it doesn't, there's no response to the serum osmolarity going up, doesn't matter, there's no response, well then you're going to have the syndrome of PPP because there's no ADH being released, diabetes insipidus. Antidiuretic hormone, arginine, vasopressin. You do need to memorize that drug, vasopressin. It's a very important drug. It is the generic of ADH. It's synthesized in the hypothalamus. It's stored and secreted by the posterior pituitary in response to an elevated serum osmolarity and a decreased blood volume. So it does regulation of water. Now, it can affect sodium because if you hold on too much fluid, you can have a dilutional hyponatremia, okay? But as far as the response of the renal tubules to ADH being released, there's one response. The renal tubules tell the kidney to reabsorb water and put it back through the circuit, okay? There are three types of diabetes insipidus. Central diabetes insipidus, meaning that the problem is because of a lesion in the hypothalamus or the posterior pituitary, your neurohypothesis. It can be also a result of severe head trauma, cranial surgery, or central nervous system infection. You can see every one of those has to do with the pituitary or hypothalamus gland itself, and that's why it's called a central diabetes insipidus. Again, syndrome of PPP. Nephrogenic, well, nephrons, you know, are the functioning unit of the kidney, so nephrogenic diabetes insipidus, that's where the kidney is no longer responding very well at all to ADH being released. It kind of ignores it. So that person will pee inappropriately. Lithium is a common drug used with people with certain psychiatric disorders that can cause them to have nephrogenic diabetes insipidus. And they'll want to drink because they are so thirsty, and they can have problems because of that. Dyspogenic diabetes insipidus, that is an actual structural lesion in the thirst center only, and the person will have a psychogenic polydipsia. And we won't really talk much about that. But here are the symptoms, whether it's central or nephrogenic or the other one. They are incredibly thirsty. They have a very high urine output. They have a very high serum osmolarity, which makes sense since they're peeing off their fluid, and now they got a lot of osmos left around. Generalized weakness due to the fluid loss. Nocturia due to getting up so much at night to urinate, and of course sleep pattern disturbance. Other symptoms affected, the central nervous system is affected. They can be mentally dull in appearance, lethargic, irritable, weight loss, hypotension because of loss of fluid, tachycardia because the heart's responding to try to restore volume. They can get to the point where they have overt shock due to the loss of fluid and circulatory failure. Diagnostics test to test for diabetes insipidus, water deprivation tests where they withhold fluids for 8 to 16 hours. You are to assess the blood pressure, their weight, and their urine osmolarity every hour. Urine osmolarity, if it's stable, are they having weight loss? Are they losing their blood pressure? If they are, then you would administer vasopressin. If the body responds, it should show the osmolarity rising greater than 9% after the vasopressin. If they don't respond, I'm sorry. I will tell you that I'm here at home without any notes, any books, nothing. I'm just lecturing off the top of my head. So I think I will stop for now, and we'll pick this back up when I go to work tomorrow because I want to be accurate on what I'm telling you. Okay? Thank you very much.